Hey y'all, welcome to breakout room number 1 on data equity. My name is Mandy Dees. I'm with CRAC. We're here with my co-facilitator, co-moderator, Dewey Doe, and we're just going to give a few minutes for folks to trickle in. I know it's hard to click that room button, or maybe it's just me because there's so many movement. And then we'll also just do a quick check to make sure all of our panelists are here. So just take a moment while we settle in, and then we'll get started shortly. Thank you. Awesome. I think we have everyone, so we can go ahead and get started and let folks trickle in if they're still deciding which room they want to be in. I don't know about y'all, but I'm still feeling all the feels from all of the morning programming and having a little post-lunch, just trying to absorb it all. So if y'all don't mind, and if I can get a community agreement on this, we'll just take a moment, just a quick minute of silence to adjust ourselves, take some collective deep breaths. If you need to stretch, just do what you need to do. And I'll just put 60 seconds on the clock, and then we'll all come back together and kick off this discussion.
Yeah.
Sounds great.
All right, thanks so much, everyone, for your grace and patience and for creating the space for us to do some more deep dive into these rich discussions that we've already had so far. And this breakout room that you're in specifically is on data equity and data disaggregation as a key civil rights issue, as a key essential strategy to reducing health disparities and mental health disparities and advancing health equity. And so far today, with all of our programming and in all of the work that we've done through this project and in so many of our rich conversations this morning, a lot of the focus has been on visibility for our communities, and really showcasing and uplifting that our right to heal includes a right to be seen. And we're holding this conversation because we know that health and mental health equity and culturally and linguistically appropriate health approaches and services can only happen when there is visibility, when there is disaggregated data that recognizes the vast diversity of our communities, when we erase myths of monolithic groups, and when we shed light on all the different social determinants and nuanced lived experiences of people of all different backgrounds. And so we really want to make it clear and ground this conversation that data equity is a civil rights issue, and health and mental health inequities and disparities don't just appear neatly defined within broad racial groups. And each and every one of us deserve to be considered and to be counted. And each of our communities and individuals deserve visibility and empowerment. So with that said, our panelists here with us today are deeply passionate, experienced leaders and advocates of data equity work who have been in the long fight for representation and appropriate care, healthcare, mental health care for all of our communities. And I'm pleased to give them the space to introduce themselves, to share what their own identity is to themselves, what they do, and what this work means to them. So to kick things off, I will do some modeling. We'll ask folks to share their name, pronouns, and organization, and answer 3 questions, which is 1, this is who I am; 2, this is what I do; and 3, this is what this work means to me. So my name is Mandy Dees, and I am the Director of California with CRAC, the Southeast Asia Resource Action Center, and I use she, her pronouns. And I am a refugee, an immigrant, daughter of refugees, sister, friend, and part of the resilient community of Southeast Asian Americans who came to this country and or from families who came to this country from experiences of war and genocide and violence and displacement. And I, in this role, help lead our health and mental health work and advocacy at both state and local levels, and make sure that our work is deeply rooted in community and the voices of our partners across the state, some of which are in this project with us and in this space with us today. And for me, this work means co-powerment with our community members, with our community partners, and other diverse communities. It means visibility for the unique lived experiences of my family, my peers, my communities, and asserting our right to heal where health and wellness is for us and also defined by us. With that said, I will turn the introductions over to our first panelist. Brittany, do you want to kick us off?
Yeah, of course, of course. Hi, everyone. My name is Brittany Butler. My pronouns are she, her, hers, and I'm with the California Black Health Network. I am a North African, Egyptian, and African American woman who is the daughter of immigrants. I have lived in San Diego all my life, but now work in the Bay Area. I am a research and programs manager with the California Black Health Network. I mostly manage a big flagship project called the Black Health Agenda, which I'll reference a lot today. And this work, what it means to me, is representation and collaboration over competition. There are plenty of resources that we can share and collaborate on and partner on in order to take up space and improve data equity. So thank you for having me. And can I popcorn?
Yes, thank you.
Okay, great. Angel.
Thank you so much. Kishe Neheya Paate, I greet you with agape love. On my father's side, I am Tarascan Indian. We identify ourselves as Indios with Tarascan descent. And on my mother's side, we are Purepecha Indians. We're also a mixture of Mexican and Spanish blood. I also speak Spanish. I speak my father's native language, which goes back probably 2,000 years. And that's how I greeted you all. I work as the Chief Executive Officer for the Bakersfield American Indian Health Project. We're located in Kern County. It is Central California in the city of Bakersfield is where we're located. I go as he, él, him. I'm a father. Have 3 children, 3 beautiful children, 2 daughters and a son. This work here, I've probably spent about the last 10 years serving just specifically indigenous populations, leading organizations such as the one I work for. But I have about a maybe 25-year career in social services. So my background is mostly in administration and government, a lot of community program planning. And I hope today to offer a lot of information as it relates to the various questions about data equity. So thank you again. And I'll popcorn it over to Rosa, if she's with us.
I think it'll be Lizette with us today.
Lizette, got it.
Hey folks, my name is Lisa Escobedo. My pronouns are she, her, hers. My organization that I'm representing is Ultimate Health Services. We're located in Los Angeles. Who I am, this is an interesting question because I'm used to doing a lot of conferences. I'm like, wait, yeah, who am I? This is a really important question. So I am the daughter of 2 Mexican immigrants. I was born and raised in LA, as you can probably tell. I was raised specifically in Southeast LA, which if you're aware or familiar with that community, is one of the communities that probably suffered the most from COVID, has the lowest participation in every election, lowest participation in every census, and usually lacks representation, but yet is over 90% Latino and immigrant. And so that defines a lot of the work that I do. I'm also a single mom of a teenager. So that's That's been rough. And in terms of what I do, I'm the Associate Vice President of Civic Engagement Advocacy at AltaMed. I will share that this is kind of my first time deep diving into the healthcare world. I've been doing 15 years of civic engagement, specifically focused on Latinos. So I ran 2 census campaigns, both in the 2010 and 2020. So did a lot of work around representation or lack of representation in census enumeration for Latinos specifically, and Latino subcommunities all across the country, and have worked on quite a bit of a number of elections. And again, just really focus on representation. Have also done worked on a lot of social justice and civil rights issue. That is where my heart is at. And so although my core is starting from the place of building democratic and political power and representation, everything else stems from there, right? Environmental justice, housing justice, economic justice. So kind of have worked on all the things these past 15 years. And for me, what the work means for me specifically is really an opportunity to be a voice for people like my parents, who came to this country with a second grade education, didn't know the system, couldn't get healthcare, couldn't get assistance with housing or pretty much anything. And so for me, it's a deeply personal issue to be able to assist immigrants, my community specifically, and be a voice for them in spaces where they don't have a voice. And so that goes all the way from voting to making sure that when we look at data and we address the social determinants of health, that we can address them in a holistic way, and that we're present in the numbers and figures that we use to do the work. And so that's me. I'm not sure who we're still missing in terms of panelists. I want to say, did Jimena already go, or am I missing no one and I'm the last one?
No, that's perfect. Jamina.
You. Hi, y'all. My name is Jamina. My pronouns are she, her, hers. I'm tuning in to y'all from Nisinanlan, which is also known as Sacramento, California. I am EPIC's advocacy coordinator. EPIC, also known as Empowering Pacific Islander Communities, is a pro-Black, pro-Indigenous, and anti-racist national organization based in Los Angeles that was established in 2009 to advance social justice through culture-centered advocacy, leadership development, and research. I am a third-generation Samoan woman, daughter to George and Lorena Afuola. My family comes from American Samoa. My dad is from Vakia. My mom is from Alao. And I am a mother to my son, Lucian. He's 10 months. He's crazy. He is also identifies as Pacific Islander. He's Samoan. His dad is Ithauka, Indigenous, Fijian, and Tongan. I am I'm an advocacy coordinator. I advocate on behalf of the Native Hawaiian and Pacific Islander community for EPIC and statewide advocacy work and civic engagement. This work to me is really more of a collective liberation piece that I see is not necessarily a destination, but a ever-changing evolution of creating a world where my son can be free and be able to roam freely and have access to everything that he needs. And we're able to, be in this collective freedom of liberating not just my community, but the communities around me. So thank you.
Thank you to all the panelists for grounding us with your beautiful introductions and just sharing a piece of who you are. I also want to turn it over to my co-facilitator, Dewey, to close out our intros before we dive into the conversation. Dewey, I can't hear you. Is it just me? Can everyone else hear her?
Well, I can't hear her.
Yeah, I can hear Twee there.
We'll give Dewey a moment.
No.
Technology, y'all, it happens.
Oh, I think she's joining your phone.
Mm. Are you calling into the breakout room via your phone?
Hi, can everyone hear me okay?
Yes.
Oh, thank you. Hi, everyone. I'm so sorry about that. I don't know what's happening with my computer, but I hear you all perfectly. So I hope this mic from my cell phone will suffice. As I was saying, I want to thank Mandy and all of our panelists for joining us today. My name is Thuy Do, and my pronouns are she, her, hers. I am with CRAC, and I'm a 1.25 generation Vietnamese American. I immigrated here with my family in 93, so I'm a daughter of refugees and the war veterans here. And I'm a sister, proud wife, and a fur mama to a Chiweenie, as well as a proud community member here in South Sacramento, where Little Saigon is nestled. And yeah, what I do is I work with Miss Mandy here as one of the California program managers, where I am able to connect and empower and work with other local and statewide partners in our networks, striving towards equity and better health, education, immigration policies, and policy advocacy for Southeast Asian communities. And what this work means to me is the fact that we're able to identify, resonate, and work with each other to uplift one another through our voices and our actions and our stories. And so that's something where I'm very blessed to be a part of and to connect with others to strengthen various communities through action and change. And so I wanted to pass it back to Mandy. And so thank you very much for this time.
Thank you so much, Thuy. Thank you all. So we're going to kick off the conversation to really ground in context and learn more about the different communities that are represented here by our panelists and folks here in the space. And the first question to kick off this conversation is just an ask for each of our panelists to share more about the communities that you represent and why data equity is so important to you and the work for your communities. And anything else you would like to add in really helping us understand why representation is so important to receiving appropriate care, programming, and support for our communities. To kick things off, I'm going to ask Brittany to start us off.
Thanks, Mandy. Yeah, of course. So the California Black Health Network, we have a lot of projects. We work on policy advocacy, but I work on research. And my main flagship project is the Black Health Agenda, like I mentioned. And a part of the Black Health Agenda is to address disparities for Black Californians in 10 different California counties. Those were chosen based on Healthy Places Index and Black population. And the reason for this is, disparities are location-based most often. And although it can trickle down from county to county as the same issue, it's most important to get the community involved in this work. So what we do is go into each community, discuss with experts, stakeholders, community members what the issues are, and use that qualitative framework plus the quantitative framework we find on a primary basis to create a plan for that county. And one of the main steps of the Black Health Agenda is to have a stakeholder meeting where our breakout sessions are anonymous, are a totally open forum. And I wanted to share a quote from that quotation. And it's anonymous. "We must be at the table, if nothing else, to get the knowledge. We perish for a lack of knowledge." Knowledge is power, and we get more done in numbers. If we keep allowing them to keep us separate, we will continue to be in our same state. And I wanted to say that this applies to the situation as well, regardless of what areas, what race, ethnicities, and identities we serve. We all know knowledge is power. So I just want to note that the California Black Health Network does serve Black Californians, regardless of gender, sex, identity, age, gender, houselessness, status. But we are a covered California provider, and we give insurance to anyone of all races, and we do direct resources to all of you fine stakeholders and pass the information forward regardless of race and identity. And I wanted to also talk about, I was going to talk about maternal health, Black maternal health, which is a huge issue in California. And the reason for that is lack of data. A lot of that is lack of data, not the main reason. The California Department of Public Health just recently put out a study noting that a Black maternal health pregnancy-related deaths was actually way worse than we thought for the past 10 years. And that is because of lack of proper data reporting from hospitals. And the consequence of that is lack of funding. Unfortunately, we have to prove our case in order to get funding. And part of that is the data. And I also wanted to talk about an experience I actually had yesterday and this past week, writing a proposal about the aging Black population. There is a huge gap between ages 50 and 65 of the Black population, not just the Black population, but all people of color. This is 1 in 3 seniors experience poor income needs. They cannot meet their basic needs in California. How much of that is people of color? We don't know. So I just wanted to make a note of that, because that is the knowledge we lack. And as I said, we perish for a lack of knowledge. How are we supposed to make the next steps, and how are we supposed to allocate our time? And how are we supposed to convince policymakers this is worth our time? Unfortunately, that is kind of how our system works right now.
Thank you, Brittany. And yes, I'll say it again. Knowledge is power. Thank you for uplifting that. Angel, I saw you unmuted. Did you want to respond as well?
Yeah, sure. I wanted to offer a bit of a segue from Brittany's conversation, as well as maybe offer just a little bit more along the lines of data. And we are data, right? This room is very filled with some very diverse people, and when we include our input into these stakeholder processes, it really allows for our voice to come to be a collection of that data. And so one of the things that I feel has been very informative for us is really that process, a strategic process in which we include the voice of everyone we serve. And so of course it's very time consuming. Data and evaluation and research is very time consuming, but everybody can play a role in that evaluation process and that collection of data for whichever agency you work for. Here at Bakersfield American Indian Health, as you know, we serve Native Americans and Alaska Natives, and we through data collection, we have realized that among our population, the most important thing is whole person care and meeting the basic needs of our people. Those basic needs often change, and so data really allows for you to be informed and really align the services that your organization offers to meet those basic needs. It was in 2019 that I came onto this organization in 2019, and I came with the intent of really looking at the county as a whole in terms of every Native American that lives here in this county, and really meeting the need and hearing the input of those individuals. So CPAN was very graciously enough to fund us, as well as the California Rural Indian Health Board, to really do a very robust, very comprehensive stakeholder engagement, using really the mental health services that Office of Accountability Commission, CPP process, and they have a framework for organizations to really use if they should do so with that framework in mind to collect data for the community they serve. And this collaborative work was done with the California Consortium for Urban Indian Organizations. And so one thing that we found through this collection of data over the course of the last 2 years is that the priority need for us, without data, you can't really know what you're really trying to solve. And so one of the solutions was that through this data, we were informed that, postpartum depression, suicide, and the inclusion of cultural and traditional practices was among the 3 priority needs for our community. So it really allowed for us to work as a collective team to address, the disparity that existed among the folks who contributed to the evaluation or to the surveys or to the focus groups. And so one of the things that we looked at was not only the priority, but then also looking at statistics to inform, do these priorities in our community, are they relevant to what's being researched across the state of California? So when we looked at suicide rates, California Department of Public Health has a statistics on death files, and so it was very eye-opening for us to realize that in the state of California versus other states, suicide by death was among the highest. And of course, they have a breakdown of counties. So, one of the things that we do here at the clinic is really focus on that integrative care, really having professionals work. We have medical staff working in behavioral health department. We have behavioral health staff working in medical department. And so integrating the care has really helped us to really treat the person with that full person care.
Thank you, Angel. Lizette, would you like to answer this question?
Sure. So at Ultimate, we serve both, as I mentioned, LA County, Orange County. We have over 50 community health centers. We're actually the largest federally qualified community health center in the country. We serve predominantly, because of where we're based, Latinos, but we're open to all. And I really think that and we serve about 400,000 patients. The other big point here that we look at closely as well is out of our 3,500 staff, over 80% of those actually live in the communities they serve. And so that's really important for us. One of the things I think that sets us apart in Ultimate is that we really operate from the place of cultural competency and cultural relevance, right? Talking to folks in their language, talking to folks in their terms, and really understanding how we talk to them about, whether it be mental illness or other illnesses, other health issues. Cultural competency has really been at the core of what we do. Our community health centers initially started off in the about 50 years ago when we had a mobile clinic site that just wanted to help out Latinos in the East LA community. It was called the Barrio Free Clinic. And it was really meant to address the issue of healthcare as a human right for Latinos. Since then, we've been in operation for about 50 years, but we've really been rooted in that sense of social justice and access. And so I was specifically brought on board to Ultimate to look at what are the environmental issues that impact other social determinants of health, and how do we make a change in the civic engagement and political structures at B to change that, right? How do we talk to folks in leadership to address the issues? How do we make sure that our patients and the communities that they come from are voting at a high rate? And so one of the things that we did is that we've had to do through our work is not just look at, we have, although fragmented, we have some data, right, on healthcare, at least for our patients, and we know the patient's needs, et cetera. But what we wanted to take into account is what were the support services that were needed in our community? What were some environmental impacts that we weren't factoring in that played a big role in the health of our communities? And so the way that we kind of look at this work, both for advocating for data disaggregation and doing some of the civic engagement work, is that we know that when a patient comes into our clinic, we can address between 10 to 20% of their health. The rest of it will be determined by environmental factors that they go back to, right? So we know that asthma, there's high rates of asthma in Latino communities, high rates of cancer, high rates of diabetes. So do they have access to clean air and water? Do they have access to healthy foods? Do they have access to green spaces? And so the way that at least my team looks at the work is, how do we change those structures to make sure that when the patient leaves the exam room, this is part of the continuum of health, right? We make their communities healthy to make them healthy. And so for us, all of those pieces require data, right? So we don't just need to know, are Latinos, do Latinos have diabetes at a higher rate? Yes. Do they have asthma? Yes. But we also need to know what are the participation rates in the local areas, and what does that have to do with the takeaway or the building up of parks and green spaces, right? Are Latinos making themselves count in the census? And what does that have to do with federal funding for various resources that have to do with housing, transportation, small business? And so the work that our clinics do, right, and our healthcare professionals do to do their side of the work requires a certain type of data. And the work that we do to build the conditions to make our communities healthy require the other portion of the data, right? The other big project that that my team had the opportunity to take on, and even though my team does civic engagement work, the sense of building messaging and campaigns and outreach efforts that were culturally competent and relevant is across the board, doesn't matter the issue. So we took on our statewide COVID-19 vaccination outreach campaign called Ándale que esperas, which in English is, come on, what are you waiting for? And so what we decided to do is use the kind of various models of community outreach, community coalition, kind of how it's done in the social justice space, right? You knock on doors, you canvass, and do that for COVID-19 vaccinations amongst Latinos. Some of the biggest challenges we had was getting access to kind of subgroup data to understand which Latinos are getting hospitalized, which Latinos are not getting vaccinated at a high rate. They were made available right throughout the kind of COVID pandemic, but not in a timely manner, not in the way we needed it. And so we decided through this effort to build up our own call center. It was a hotline, 844 Ya Ándale, and that was everywhere. And we received we executed about 14,000 vaccination appointments just through the hotline in 11 months. And so through that, my team decided that we were going to collect data that way, right? That we were going to, and it was all anonymous information, but it was the very detailed data that we needed to make certain assessments on how we focus the resources of the campaign, who was not getting vaccinated, what were they saying? And we went back to kind of the initial thought that I had, right? It was a lot of it was around support services. It was about transportation, access to childcare. It was about losing wages, right? If they had to take a day to go get vaccinated or take a day to get tested. And so, for us, that data became the core of the campaign, but it became the data that was not accessible in other spaces, right? And it's very similar. The last thing I'll mention is it's very similar, for example, when we're looking at census data. So something that we've been working on the census front is how do we design the census form in a manner that will allow us to collect more information about Latinos who have only one category, but as folks know, Latinos are not a monolith. a Mexican Latino is very different than a Cuban Latino and very different than a Salvadorian Latino, right? And so we've been kind of working on that to, again, make better assessments on how do we target our community in a more intentional way, and in a way that the data that we have access to on Latinos also shows that they're not a monolith, and we need to learn more and do more in this way. And again, how do we access data that assesses social determinants of health, as well as the support services needed to address holistic health for our work. I'll leave it at that.
Great, thank you. I wanted to, before we move on to the next question, Jamina, would you like to respond to this one?
Yeah, sure. Thank you. So just really quickly, I think Native Hawaiian and Pacific Islanders in California actually reported some of the highest rates of infection and death during COVID-19. And I bring this up to say, I think one of the critical pieces is that the importance of disaggregated data for NHPI specifically was even more underlined, right? We saw issued data on our community that was unclear. It didn't specify subgroups within the NHPI umbrella properly. There was a lack of inclusion and conversation when data was being disseminated, and our community was suffering extremely from this, right? Because the resources were not being distributed properly. NHPI is a minute label that accounts for a large community of, from Samoans, Italka, Fijians, Marshallese, and Native Hawaiians. And we often hear that it's too difficult to disaggregate our smaller brother and sister islands because of the sample sizes, but they are actually the communities that are needed the most when we're talking about equity and accessible care. Currently, the Compact of Free Association, or our COFA citizens, include Micronesian, Marshallese, and Palauan communities in the US. They actually now have access to full scope Medi-Cal, and it's up for renegotiation. So in order to continue advocating for our smaller communities like our COFA migrants, we desperately need disaggregated data. It's deeper when you look at how many islands represent the NHPI community, right? Data is narrative changing, and it's storytelling through demographics. And it's also asking the right questions that allows us to fully explain the capacity or severity of social issues. And I think, just to conclude, I think even though we know that storytelling and narratives are lived experience of our community that we feel and we're able to experience, data is just a route that's needed to develop policy and advocacy in the state. So that's all I wanted to share. Thank you.
Awesome. Thank you, Jamina. Thank you all. I think it goes to show that, like with these caveats and these obstacles that we're facing just as a community, I'd like to dive a little bit more into that question where you would see those opportunities, as well as, if you would like to elaborate in the challenges in the data disaggregation when it comes to accessing mental health services and treatment within your community. And so you're welcome to hop on, Jamina or Angel.
Is it for question number 2? Yes. Are we on question 2?
Question number 3.
Question number 3. Got it.
Yes.
Great. Well, one thing I think that is helpful for us is that, we have listened to the community voice through lots of, research, lots of evaluation. And one thing that I feel we have achieved well is listening to that voice. As you can see on my shirt, I have what's called the medicine wheel. It's also known as the dancing circle. There's many references in Native American to the medicine wheel. It's the sacred hoop as well. But one thing for sure that we all agree upon in terms of what's important to Native American communities here in Kern County is that the medicine wheel represents really the physical, the mental, the emotional, and the spiritual realm of wellness and healing. And so as part of our duty, our fiduciary duty to ensure that all of those that seek treatment at our healthcare facility, that they receive fundamentally those 4 elements, those 4 core elements of what the Native American perceives to be value to them. And so here, one of the things that we have Ms. Donna Cubitt. She is Native American. She works as part of our behavioral health system, and she's the cultural coordinator as well as a substance use disorder counselor. But and I have learned so much from her. You know, she's so great. One thing that we focus on is not necessarily labeling certain services as mental health, but rather focusing them, reclassifying them as more of sacred health. And that's the sacred right that we as an organization, as a healthcare organization, have valued to be fundamental to our practice. So what I have here is sage, smudging, saging, different terms used in Native American communities to practice these rituals as a way of really balancing their lives in terms of mental health. So, you know, we view access to mental health very different, perhaps, than many other organizations, but what we have found through anecdotal study is that by including or being inclusive of the community input, it has led over the course of the last 2 years to a tremendous amount of referrals or self-referral or referring from other agencies to our organization to treat individuals with, say, behavioral health and mental health challenges, because of the value that we place in the cultural or the ritual or the traditional means of healing. And so, you know, so to just share a very quick example, if you were to come to our clinic, our providers would, instead of saying, hey, how are you feeling today? What's the level of pain, right? And we have this traditional Western philosophy of pointing 1 through 10, I feel, 8 in pain. We say, hey, point at the medicine wheel. What's more important to you today? Do you want to focus on the physical? Do you want to focus on the mental? What is it that you want to focus on today? Where is your pain? And how can we saturate that? How can we close the chasm of pain and suffering? And so again, it goes back to sort of Q1 where we're talking about basic needs, but what we have found is a tremendous amount of healing and resiliency through this practice. And so we continue to focus together with everyone on that balance that we have found to provide to our people. So I hope that kind of answers the question in a more unorthodox way. But these are the cultural learnings that we have had through evaluation, and this is that sort of community voice, the feedback that we get that by you doing this, it has led to me being better, feeling better, or yes, I have increased my wellness to a more balanced life.
Wonderful. Thank you so much, Angel. Brittany, would you like to respond?
Sure, this is a big question. I was thinking, I was just typing some notes because I have so many thoughts, but I was thinking about what Lizette was saying about the census. And one challenge in disaggregating data, especially for Hispanic, Black communities and those that have subgroups, is that it's not a true representation of what is going on in each group, which is how here at the California Black Health Network, we identify disparity. We identify it by community. We don't identify as a monolith. So one challenge we've been running into is distinguishing between African American communities in California and African immigrant communities in California, which face there's similar disparities, but face mental health disparities that are rooted in culture and are rooted in history. And I can't speak for each group as a monolith, but as someone from a African immigrant community and that is African American, there is almost in the mental health field much stigma in both, but for almost different reasons. So that is something I want to touch. I want to get to the last question to touch more on this, but I want to emphasize that data, although may look the same to many people and to us, it has a story, and it has a story underneath the layer of this number. And I do want to speak to our work in each community and how does San Joaquin County differ from LA in terms of asthma rates and why they exist and why they're even, maybe they might be the same, but they have totally different reasons they exist. So I'll touch on that later though, but thank you.
Thank you, Brittany. And Lizette, how about you? Do you have any thoughts?
Very similar to what Brittany mentioned, right? In terms of, with Latino communities specifically, and really the generational gaps, both immigrant foreign born, US born, having access to that specific data can tell you a very different story about both Latinos, right? Especially when it comes to accessing mental health and access to mental health, right? There is, with Latino immigrants specifically, there still is a lot of stigma of not just about whether they have access, but what does it mean to access, behavioral health. And so, which is kind of changing. And it was interesting because I was talking to a colleague this past weekend in DC, and they were sharing how with younger Latinos, kind of your Gen Z Latinos, mental health is something that they're educating their parents about, right? And that is very, very different, right? Across generations. And so understanding that, and this was all anecdotal, right? Because there's no data that's going to tell us whether high school age Latinos who are first generation are more receptive and open, and it's something that they need and want access to. The other piece specifically around mental health that we took on, even again as a civic engagement department, is we actually work with the LA Unified School District to survey some of our patients within those service areas who were parents, to ask them the impacts that COVID had on their school-age children, just to get a sense of what are the services and support that we were going to provide to them. And we actually worked with the district itself to get them kind of back that information. Mental health rated very high in that a lot of the students felt that where they struggled most during the pandemic, and this is kind of elementary through high school, was around issues of that had to do with mental health. And so we learned that just through kind of this sub-survey that we did. And we were doing it because we wanted to engage parents also on the school board elections. So we decided to ask these other questions. But it's again, it's very similar as what Brittany mentioned with Latino communities, is really having access to that sub data that tells us a bigger and better story about again, accessibility and who is accessing, right, as well.
Thank you, Lisa. And yes, it's so important in the data equity work to emphasize that it's about nuance and more specificity in data and information, and to really uplift all the different experiences unique within our communities, within subgroups, and then also incorporating all the different intersectional experiences that our communities and community members hold and feel. And with this discussion on really the how and where the opportunities are, I really want to steer the discussion toward the advocacy conversation, because so much of this project is focused on that locally, but also so many of our organizations have done such meaningful work in the policy change space. So I want to ask Jamina to kick us off in terms of answering this next question, which is if you can share a bit about the policy scene that you've worked in, and what has your organization done related to data equity and data disaggregation to ensure meaningful and nuanced data for your communities, whether it's policy creation, implementation, or something very specific to health and mental health care access that you've worked on. For you to just share a bit about what you've done, and if there's anything you also want to add for opportunities and more work to be done and opportunities in the future. So Jamina, I'll turn it over to you.
Thank you, Mandy. Yeah, I think as far as EPIC, we are also in constant conversation at the statewide and national level to ensure that the NHPI community is being advocated for. We don't specifically co-author legislation at the moment. We are a team of just a new team of like 8 folks, and we're functioning at a national and statewide level. And so our capacity looks different for our community. And so when it comes to advocacy in our community, it's mainly continuing to be in every single conversation at any social justice issue. So though our top 3 are education, immigration, and health, we're also in housing, we're in youth justice, we're in all these spaces doing all these different hats to make sure that we're continuing to encourage this narrative that our communities are not being advocated for, that we need the disaggregated data for our community, and we need the numbers and we need the narratives. And I think we've also seen that like our community functions and we have such a mutual aid for one another. COVID has really showed that we were able to take care of one another without relying and waiting on data disaggregation and waiting on federal government agencies to move. And so what we picked up on was our community health workers, right, really coming in. And when I came into EPIC, I actually was a community health worker. And so that was one of the key pieces that we seen that was providing community aid and mutual aid for not just Sacramento, but also in NorCal. We had those folks providing that aid while we were continuing to advocate behind the scenes for disaggregating data. We also know that we're not going to wait for counties to respond back to us for the meetings and for the continuous, ledge visits and things like that. And so data disaggregation is emphasized, and we're continuing to move our narratives with or without folks. So.
Thank you, Jamina. And EPIC and CREC work really closely and have collaborated a lot on really difficult and challenging, but also meaningful policy change to do help the data disaggregation work. So I always appreciate your insights and thought partnership, Jamina. Angel, I know a lot of your responses, you have shared a lot of how much the work is rooted in community and in collaboration with the communities that you work with. Do you want to share a bit more about the policy or local advocacy work that your organization has done in collaboration with community and with community input?
Yes, of course. One of the things that I think can speak loudly to the advocacy work that our community members have done is really participating. We have about 5 key events where in each of these events, they're cultural events, we include a portion of community evaluation. And a lot of that feedback makes it to the consortium, the California Consortium for Urban Indian Health, as well as the National Consortium for Urban Indian Health. And those 2 agencies are really sort of the authors. They co-author legislative advocacy for Native Americans, Alaska Natives in California and abroad. Much of what we focus on is like data, electronic health records integrity. We'll ask questions about, what's important to you in terms of healthcare, and what would you like to see? What is underfunded? What's funded well? What the community with the community involvement. It has led to the formation of various cultural groups. We use terms like talking circles to really engage in community discussions about these various topics that I've mentioned. We use other platforms, and now the community has really leaned on us to really be that sort of facility, that organization that sort of has this community wellness center, if you will, for inviting the community abroad to engage in the design making of healthcare across Native Americans. So much of that has been recorded through various funding opportunities. The California Rural Indian Health Board gave us some funding for a really really robust community health assessment. And there was a co-authored narrative report with feedback informing, just sort of kind of the larger stakeholder collaboratives about that work that was done here in Kern County. We've posted that on our website, shared it across, anybody who wants to download it. And there are other venues that we use, like the quality assurance, quality improvement. committee. That's another committee made up of not only board members, executive staff level partners, as well as people with lived experience, right? Like we want to include them as well as part of, really designing policy, influencing policy and practices, standard operating procedures and things of that sort. So I think in terms of what we didn't have before and what we have now, it seems like the community input has really redesigned the way we operate. And we have found that to be sort of kind of like the bridge to really meeting the need of the community, right? We can now say, yeah, we include the community versus it's just words on people's mouths when they use these types of identifiers to say that they're doing all this work in the community. So via these different platforms that are recording this data, we can stand strong that we are including that community as part of our processes. Thank you.
Thank you so much, Angel. Lisa, in all that you shared about the research and the intergenerational learning that has been happening in your communities with youth and their parents, how has that supported some of the advocacy work that you've seen through your organization or through community stakeholders?
So we actually, at Ultimate, the organization itself saw the huge need to advocate across the board on many issues, right? Whether it's, data disaggregation or it's access to healthcare, workforce, right, development. So we actually established a government relations department within our organization, which includes government affairs, and it actually includes my department, civic engagement. And so what kind of our entire team is tasked with doing is advocating for, again, not just healthcare issues, but other underlying issues that affect healthcare as well. And so we have quite a bit of things that we do to engage our patients and community members with our advocacy efforts. We actually have something called the Advocacy Leadership Academy, which engages patients and then young folks from the communities that we serve. And we actually train them on like Advocacy 101, Civic Engagement 101. Who is your elected official? What are the committees? Who makes decision at the county level, city level? And then from then on, we actually identify some priorities for them to kind of focus on that would, in essence, make our communities healthy. That's kind of the broader goal. They're not necessarily kind of your promotoras model, but they're more of your community ambassador model. And so some of the work that they'll be taking on in the coming year will be on, we will be training them and providing kind of train the trainer opportunities on data disaggregation and really making the issue of data to address racial equity something that is more common in conversation for our community, because when we're not involved in those conversations, then those issues aren't heard, right? And so we're actually working with the Latino Coalition for a Healthy California to develop those trainings and identify those opportunities for our existing leaders to take that on. And in addition to that, I know that we've advocated in the past for the Health Equity and Racial Justice Fund that was unfortunately not funded by the governor this year, but we signed on to. So we're looking at what are all those opportunities to address the issue and kind of incorporate it into the healthcare priorities, which again, for us, we have about 7 or 8 pillars in our work. This year, we also are working closely with the Leadership Conference Education Fund, which is a national kind of civil rights organization, to address the issues of health equity, specifically statewide in California. And so we are now part of the State Census Action Network, who will be addressing the issue of data disaggregation more broadly, but also looking at what are the different state models that other states can model after, right? Even though we have a lot of work to do in California, in many instances, we do a lot better than a lot of other states kind of tackling the issue of racial equity. for some obvious reasons, right? And so we're now engaging in that work. We'll be engaging in that work over the next 2.5 years. But again, we also include these conversations around data access in all of the work that we do, specifically around COVID response. Our organization did quite a bit to work both with LA County, Orange County, state, and then it required federal conversations because of access to vaccines. If folks remember, when the pandemic initially started, access to vaccines was a huge issue. And it was something that I know our government relations department had to really kind of fight for at the federal level. And so with that also came, as I mentioned earlier, these gaps in data reporting and data access to make better assessments of where we needed to address the issue of access equity in terms of vaccines. So we've been doing kind of a lot of work on the advocacy side, not directly on the issue, but moving forward, we will be tackling this work in a way that brings in community voices. It's an important topic and it's a necessary topic for communities to understand and advocate for, but we haven't been brought into those conversations, right? And so we, this past year, we actually took on the very easy topic of redistricting in the same manner. And it really provided our patients and the communities we serve this sense of, okay, I need to pay attention to redistricting. It's really important and it impacts me. So we want to do the same around community education and community input as it relates to data disaggregation and the impacts of addressing racial disparities within that. So it's kind of going to be our experiment for the next 2.5 years. But again, what we've done in the past and what we'll be doing over the next couple of years.
Yeah, thank you so much, Lisa. I think that is a wonderful transition into how the feedback for the next question, how the feedback and engagement from the community members regarding some of these actionable solutions to improve the health outcomes in LA and LA County and in the OC, and as well as the well-being and dismantling the health inequities within the system of care. And so I'd like to have Brittany kick off this response. And yeah, thank you.
Sure. So through the Black Health Agenda, we have got a lot of feedback about what we should do next and what the state should do next and what other organizations should focus on in terms of not just data equity, but policy advocacy and like Lisa said, educating more on how to advocate for yourself, your family, and your community. And the communities we worked with have actually had the same sentiments as Lisette. And I mentioned before that data really has a story, and that social determinants of health is a historical issue. It's based off of the location, geographic location's historical trends, and the state's historical trends. And generationally, disparity can change your biology over time. And trauma, unfortunately, for a lot of people become the norm. And in that, you don't really notice or feel changes in your body, changes in generation with your family, or have noticed that it is an issue, that maybe you have asthma or diabetes. So we look into disparity on a county level because of that reason, because trauma is rooted in history and this data is rooted in history. For example, like I said, with asthma, Black folks in all of California have high rates of asthma compared to other races, but mostly their white counterparts. But in a place like the Bay Area, that it could be heavily for the reason of the terrible fires that happen almost every season. And for San Joaquin County, it's a thriving agricultural hub, an industrial hub, and it also sits in a basin. So any and all pollution that comes from the West, or LA and San Diego, falls into the basin of the Central Valley, and just something you can't escape. That's your home. So in terms of that feedback, we want the community has communicated to us to really focus not just on putting a bandage on asthma, for example, or just any issue, but to address why they may exist first. And coincidentally, when you address when they exist, it trickles down to almost every condition, mental issue, well-being, livelihood, where you eat, work, sleep, live, walk. And I also see this actually in suicide rates as well, and I think that's the second point of feedback, is to communicate this data in a culturally competent way that does tell a story, and also reframe it to understand what's actually going on. So for example, in suicide rates, I know, and for every race and ethnicity, almost every race and ethnicity, including the Black population, the suicide rates are less than white counterparts, and that has been a historical trend. But over the years, especially from around 2015 to 2019, for the Black population, that has increased by 30%, and that is not a trivial thing, and has either decreased or stayed steady in a lot of white communities. So what is that story? What is it telling us? Why is that the same case for Black youth and Hispanic youth and Asian Pacific Islander youth? This is a trend that we have seen in the past 5 years, especially through the pandemic. And then I'm just gonna one more third point of feedback. There is a heavy need for a centralized location for resources, not just data resources, but where to find help and where to find next steps. And not just from us, from the California Black Health Network, but working with someone like Lizette or Angel, or how can I and how can the California Black Health Network spread resources and be centralized for the Black community in order to help their family members, their friends, themselves, because identity is cross-cultural, and many of us have multiple identities beyond, I'm just not a Black woman. So I'll just end there, and thank you for that question. Yes, intersectionality.
Yes, absolutely. Intersectionality. Thank you, Brittany, and thank you, Estrella, for your comment. I'd like to pass this question off to Jamina on how the feedback that you're receiving from your research and from your communities been able to help improve their health outcomes and the well-being.
Yeah, thank you. Sorry, I'm sitting with that question. I think we've seen our community move in such a different space. I think we've also seen, like, when we're talking about dismantling health inequities and systems of care, our community is now much more aware of who they are, right? Like, they're much more aware of their surroundings, and they're much more aware that there's a larger collective liberation in this fight, and that it's bigger than us. And so we've actually really seen, and I want to say one of our panelists had mentioned it, is that this current generation, they're really sharp. They're really sharp in knowing and being really tentative to who they are, but also what our community's needs are. And so the feedback and engagement from our members are, like, as far as actionable solutions and improving health outcomes, has been a lot more of an uproar and has been a lot more engaging since COVID and since the pandemic. And I think I continue to talk about the COVID and pandemic because it really was an exacerbating time for our community. I think it really underlined how much our community's needs are lacking and not being met. And I want to say also, one of the panelists had mentioned it too, like, these were always pre-existing health conditions, and that COVID actually really more so underlined those things, and also really underlined that the need for social justice movements and the need for community and collective community care. And so we've seen much more of our community starting to have harder conversations around mental health, starting to have these deeper conversations about how can we dismantle our internal structures to be able to work toward a collective liberation for not just our community, for Black communities, Hispanic communities. And so we've been moving in a really strong way. And I'm actually really encouraged by our up and coming generation because they're in tune with their feelings. They know how to move and they've caught on so much more quickly than it's taken some of us to kind of move. And that's encouraging for me. And so I love to see it, and I love to see our next generation moving in such a strong way.
Oh, I just realized I did not unmute myself. Sorry about that. I was like, oh, having the commentaries and so thank you so much for that, Jamina. I'd like to pass this question off to with the last minute we have, or like the last few minutes, I'd like to open up this conversation to the group. I know that we have some questions from our participants, and so we want to ensure that your questions are addressed. And thank you, Jamina, for responding in the chat. And the question from, and please forgive me if I've mispronounced your name. Is it Estrella? Following up on the questions. Oh, Estrella, thank you. That how do you handle data disaggregation? So for example, working for a county provider, we use federal race and ethnicity categories for data collection, but these also vary by funding requirements. One question that has come up for Estrella while listening is how to handle these categories. Do you meet with the community to see these categories that are important there? And additionally, for Native Hawaiians and Pacific Islanders in data sets, I see these groups included with Indigenous groups or with Asian and Pacific Islander groups. And what are some of the practical learnings that you all have learned in relation to how disaggregated data in a way that serves the community best?
So do we just jump in and answer that question? Or, you know, I am very familiar with the race, ethnicity, gender, and age for county systems. Working in a county system, I became very familiar. And there's different models for measuring data. I think I'd like to answer that question by saying this, that when I came onto this organization, I met with all the executive leaders and I asked them, okay, I'm so-and-so, I come to you and I want this service, do you have it? And what I found is about, of the 15 questions I had, almost every question got a no. No, we don't have that service. No, we don't have that service either. No, we don't have that service. So you first have to really start by saying, yes, we will provide every single service any person comes through our doors. And how do we do that, right? And so you do that through really a collection of data. What is it that is needed? What is the priority need being asked? And so, you know, through whatever mechanism your organization collects data, it should really evaluate, you know, really what those needs are, whether it be on the basis of age or gender or race or ethnicity or culture or ET, all the things that you can really track data. It should be really forming very specific and very detailed to what that community need is. And so I think if you start there, regardless of what mechanism you're using to measure data, it's really more about the service. Do you have the service that meets really the data or the need that the community is basically informing? So I think that in the case of us, we began to really shift from no's to yeses. You know, one example, pregnant woman out our clinic doors, homeless, saying, can you help me out? Can you put me in placement, right? They don't have to fill out a 15-page or 15 questions to see if they qualify and they're eligible. As long as they're Native American, they're eligible. We put them into housing for 9 weeks and then we figure everything else out.
Awesome, thank you so much, Angel. And I wanted to share Jamina's response to this as well. So she responded, it's actually quite difficult when we look deeper into how data is collected. And so, for example, if we have someone who is half Samoan and Tongan, it would fall under Samoan because it's a larger data set. We've rallied behind encouraging our NHPI community to fill their census from 2020 because we do know how much of the terminology comes from federal levels.
I would agree with that. We have the same issues in collecting data, like I said, and saying African American versus African immigrant, and then if you're African immigrant, where you come from, what country did you immigrate from, and it is difficult because as of now we don't have a additional system that accounts for these subgroups. So in the meantime, right now, what we do is we heavily weigh the qualitative data we collect through all of our community convenings and community interviews, and to specify, okay, in this subgroup, these are the reasons, or this is what may exist in this subgroup that we can't see, or that is not specified by subgroup. So for now, we just trust our community experts and elders to give us context until there is a better system federally to account for multiple subgroups.
The quick thing that I'll add is that there is a, so I'll put my census nerd hat back on, is that there is a huge national effort right now with the State Census Advocacy Network that I mentioned earlier to, they've been sending letters to the OMB since the 1990 census, because the question on Hispanic origin was actually not added to the census until 1970, which is when that data started getting collected. But right now, if folks look at the census form, it asks race and then it asks Hispanic origin because it's race and ethnicity, right? And that's one of the reasons why other race has become one of the largest races in the country. It's because most Latinos go to any household and you ask them what race and they say Latino, you say that's an ethnicity, and then it just throws everything off, right? And so there is a huge effort to advocate specifically to the OMB to start reviewing their 2030 census form. And so there will be some opportunities for public comment through the Federal Register to basically say, we want a review of the form. I know there's other kind of LGBTQ subsections too on identity that the LGBTQ movement has also been requesting review on. So there is an active effort now because the Census Bureau or the Department of Commerce just received approval for like the maximum level of funding to prepare for 2030. That funding is going to roll out in 2023. And so 2023, I think, is also going to be a year for us as advocates to go to the OMB and say, okay, like you're the standard for data collection, right? And the standard for data provision. And so we need to review this form, starting kind of at the top level and how it trickles down. So I know we'll be engaging in some of that with our national partners, but I think it's a good opportunity as we prepare 7 years in advance for the 2030 census.
Are we forming a coalition right now? Is it?
Let's do it. Let's do it.
I don't know if we got our host muted. I don't know if there's any other questions, but with the sincere apology, I have to jump off this call. And I want to say to my colleagues who were on this panel, thank you so much. I was inspired just by hearing you, Lisa, as well as you, Brittany. I offer you guys good medicine and well-being to all. Thank you again for giving me the opportunity to present, co-present with you all, and to be part of this space. And I hope to see you around, hopefully at some conference or another. We hopefully will cross paths. Again, thank you, and my apologies for
Thank
having
you.
to drop off. Thanks.
Thank you, Nell.
Okay, now. So sorry, my computer screen was glitching, so there was a little bit of a delay. But yes, thank you all so much for the last few minutes here. We want to extend our gratitude to our panelists, Brittany, Isa, Angel, and Jamina for joining us, as well as our CPEN staff who is helping with us in this breakout room. And so I wanted to conclude in regards to some of the takeaway points with this really insightful and deep conversation that our collective fight for data equity and liberation holds so many commonalities to uplift the most invisible communities and nuances in the experiences that we have individually and that we share together, to push for the cultural and linguistically appropriate care on both the medical and mental standing, and to empower those directly impacted, as well as include the social determinants of health and intersectionality into mental health wellness. And one of the things that stuck out to me is that knowledge is power. And, like the more we're able to learn from each other and, across the counties, the states, across this nation, we're able to, utilize that collective knowledge and have just better data equity, because like our stories and our experiences is what creates this data. And I wanted to pass it off to my co-facilitator, Mandy, for your thoughts.
Thanks so much, Dewey, for wrapping us up and giving us a quick grounding and summary to close out the conversation. I just wanted to open the space to all of our panelists. If there are any closing statements you'd like to make, anything last minute that you'd like to share before we end the conversation, we'll just give folks a moment to reflect, and feel free to unmute and share if you'd like.
I just want to say thank you to our co-panelists, Lizette, Jamina, and Angel, who's not here, but I'm really grateful to have met you both, and thank you, moderators. Jamina, something you said at the beginning was you wanted to make this world better for your son. I just had a second nephew. I'm a 2x auntie, literally 6 days ago, and I'm actually here in San Diego visiting, and he is a Black boy, and I'm confident with everyone here working on these issues and sharing their stories that he will grow up in a more equitable world. So I appreciate all your efforts.
I would just add, I think I always tell folks, like, I come from the space of civic engagement, right? Like Latino and Latino politics and census and all that has been